Good afternoon, everyone, or good morning, depending on where you're joining from today. Welcome and thank you for attending our webinar on coordinating timelier responses to nitazenes and other synthetic opioids and emerging drugs. My name is Rita Bryan. I am the Senior Project Officer in the Workforce Development Team at Pennington Institute, and we're a not-for-profit organisation focusing on supporting cost-effective and approaches that can help to maximise community health and safety in relation to drugs, which includes pharmaceutical medicines as well as alcohol. I'm joining you today from Wurundjeri country, and I'd like to acknowledge the traditional owners of the lands where I live and work and pay my respect to Aboriginal elders, past and present, as well as acknowledging the traditional owners of the various lands across where our audience is joining from, mostly probably from Australia, but also Aotearoa, New Zealand, and forgive me if I've said that incorrectly, as well as elsewhere. So the format today, fairly standard. It will be a 90-minute webinar. We've got 4 presentations to get through with our wonderful guest speakers, who I'll introduce in a moment. And there will be some short time at the end for audience Q&A. We may not be able to get to all of your questions, but we will most definitely do our best. And just to acknowledge some housekeeping info, the chat function for Zoom is disabled for the webinar, but we do welcome you to use the Q&A function that's there on your screen. Only the panelists will be able to see the chat during the Q&A during the session. We will get to those after all the presentations are over. Just want to let everybody know the webinar is being recorded. We will make that available on the Pennington Institute website over the next few days. So moving on to our speakers for today, we are going to start off with Sarah Helm from the New Zealand Drug Foundation, who will speak broadly about New Zealand's response to emerging drugs, particularly nitazenes and other synthetic opioids. Then we have Jen Vermeulen from the Drug Information and Alerts Aotearoa, New Zealand, who manages High Alert, which is hopefully you're familiar with New Zealand's drug early warning system. We'll follow that up with Jared Brown from the New South Wales Ministry of Health, who will then speak to us about the New South Wales surveillance and early warning system they have there. And our final speaker is Richard Bray. Richard Bade, a Senior Research Fellow at the University of Queensland, who will talk to us about wastewater monitoring for nitazenes and how that fits into early warning systems and other responses. So without further ado, I think we're going to get started and pass on to our first speaker, Sarah. Thanks for joining us today. Sarah's the Executive Director of the New Zealand Drug Foundation, an experienced leader and CEO, driven by lived experience and work at the forefront of leading change on health, youth, social and environmental issues. So that's a suite of sectors you've been across. Sarah's experience include working for the Department of Prime Minister and Cabinet as Strategic Communications Manager for the COVID-19 response and for the Alcohol Advisory Council, Health Promotion Agency, as well as the New Zealand AIDS Foundation, and was head of the New Zealand Association of Adolescent Health and Development for several years. Sarah, as I said, Sarah's going to talk to us about responses in New Zealand in relation to synthetic opioids and other emerging drugs with the view of reducing harm across the community. So when you're ready and we've got your slides up and ready to go, I'll hand over to you, Sarah. Thanks again for joining us.
Yeah, kia ora. Thank you so much for having me. And it's really, I think we all know in harm reduction and overdose prevention how important it is for us to network across countries. We are oftentimes trying to respond to emerging threats that have never been dealt with before, and sharing little bits of progress and new responses that we've had to create is so important to us being successful in preventing loss of lives and harm. So thank you so much. We learn a lot from you guys and from others, and I'll touch on some of what we've learned from others during this presentation. I've come up with a really great title for my presentation, which was the same as for the entire thing. Clearly, I wasn't thinking very creatively. So let's move on to the next slide, I think. Yeah, kia ora. I'd probably just introduce myself while we're doing that. My name's Sarah Helm. Yeah, so I whakapapa to our southern tribe, Ngāi Tahu, here in New Zealand, and also to parts of Europe, Scotland and Germany in particular. And the Drug Foundation is a national non-profit organisation, although sometimes we get mistaken for government. We are both a policy organisation, but we also incubate and help to create new harm reduction responses in New Zealand in particular, and new ways of doing addiction treatment. Okay, so moving on. I've been asked to speak a little bit particularly into how we work together in Aotearoa in New Zealand and how that is contributing to successful work. So I'm going to focus heavily on that, but also touch on some other things that we're still trying to progress, and we'll speak specifically to a couple of things around the Nitazenes in particular, and forgive the different pronunciation. I know there's disagreement about how it's said, but anyway, I'll do my Kiwi Nitazene. So first of all, we had an issue with a group of fatalities a few years ago now, due to synthetic cannabinoids, and off the back of that, my predecessor, Ross Bell, was able to push for a number of interventions and be able to stand them up. And I've been lucky enough to work with our team here, who work very hard to make them happen. And one of those is our acute community of practice. The community of practice is essentially a network of primarily front-facing grassroots organisations that are working directly with people who use drugs. They might be people in the housing sector, the social sector, they might well be people in government roles as well. And that group has become increasingly important to us. So it started out as a way of us sharing emerging harm and hearing about new batches of synthetic cannabinoids that had different potency and were causing harm, so that we could respond to them and know what was happening. It's now super important to us when we're dealing with new notifications and alerts. So we will reach out. So we'll both we connect with that group to impart knowledge that we know about, but also to hear from them what is going on in the community. But we also use that community of practice when there is a drug notification or a harm event that we're aware of, to reach into that particular geographical area or specific community to mount a response. So, for example, we were aware of a notification that had occurred a couple of years ago where there had been particular harm in the sex work community, the rainbow sex work community. So we reached into our rainbow and sex worker networks in that particular geographical area to make sure they were aware of it, because even if we get our notifications on the main news channels, they're not necessarily consumed by the community who are most at risk. So we use that community of practice to be a part of our frontline response. We also use that community of practice to help stand up responses where we might need to move in and do a bit more in a community where something harmful's been identified or something new. So that's been a really important part of our entire response, actually. And I wouldn't underestimate just how much that's contributed to us being successful here. Well, successful, sorry, not entirely successful, but the bit of the success we are having, that is one of the things. Of course, you'll all know we're lucky enough to have legalised drug checking here. Again, that was off the back, again, of that harm event partly, and off the back of really hard work by a couple of fantastic individuals in an organisation called Know Your Stuff, with support of my predecessor, Ross, to incubate drug checking before it was legal. But not now being able to operate fully legally means a number of things. The confidence, of course, of people to come into the service, etc. You know, all of that. But what I would also say is that we're fully funded, so we're able to operate in different spaces. We have static clinics as well as clinics at festivals, etc. There's a requirement we were able to obtain for all services who are running drug checking services to have a harm reduction approach. So a harm reduction conversation is part of the drug checking experience, whoever's running the drug checking service. And we also feed that information, of course, into our early warning system. So that is sometimes the reason for the notification occurring. Sometimes if it doesn't meet the threshold for high alert issuing a notification, we can, as an organisation, if we were the one who detected the substance, still put out some information ourselves. And that's also been incredibly helpful. So, for example, last summer we saw some LSD be N-bomb, or a different version of N-bomb, if you like. There hadn't been fatalities occur, but we were aware that it had come from multiple locations around the country, and there was a lot of it at a big music festival we were running drug checking at. So we put out information ourselves at that point in time to make sure the community were aware of it in case of fatalities occurring. One of the other fantastic bits about, and actually, so I should also say there are three main providers of the drug checking service: Know Your Stuff, ourselves, and essentially our Southern Needle Exchange. But we also have a national science lab involved, and they help manage some spectrometers that are available to us, as well as verifying the results of any tests that we're concerned about, So all of those things have been super helpful. We also have coordination between the drug checking providers, and that is another really important part. So if we're encountering new issues, or because it is a relatively new service, new ways of operating that need to be addressed, having those relationships across the providers is super important and helpful. So this relational stuff you'll pick up as a big theme of ours, I think, and certainly Jen, who's speaking next, we work really closely with High Alert, who are the ones who issue the notifications. And I won't go into detail on Jen's work, but she'll probably be doing that for us. But yeah, High Alert go through a process around notifications, and we see our role as feeding into those notifications, providing information into, and then making sure the communities who are most likely to be impacted by any harm are aware of them. One of the things that we've also been able to do is purchase fentanyl and nitazenes test strips to empower the community to be able to test their own substances. So really pleased we've been able to do that. We're currently distributing those through our online store and through partners. However, we both this and our community of practice, so I think it's really important for us to always be continually improving and to be looking into addressing inequalities and making sure the parts of the community who are less able to access stuff get the harm reduction intervention. So we're doing some work at the moment, for example, around how to engage more Māori in an acute community of practice, maybe a special one. We are working on a particular strategy around deploying nitazenes test strips in a way that are going to be as accessible as possible for our under-homed community or our homeless community, as well as for our Māori community. And within that, we're also thinking about our more heavily criminalised parts of our community. How do we ensure that they get access to these test strips? So we're still developing those parts, but I would say if I was to start again, I would probably start with those communities in mind and being in partnership with them right from the get-go. Not to say we haven't involved people, of course, but we can always do better. The harm reduction focus, we're working alongside event organisers, which you all will be here in Australia as well, either ourselves or partner organisations like Know Your Stuff are. We're working with hosts, venues for music events and those kinds of things also. One of the things that we've started to do as well is make sure across the house, when there are significant drug events occurring, that our political spokespeople, both within but also across the non-government parties, are aware. Oftentimes MPs are asked questions, even just on a personal level, and electorate clinics, etc., about what's happening in the community. So supplying them with information has actually been super helpful for us, and that has helped to ensure quality of information across and an understanding actually of drug events, which would also lead me to another important point, that all of this has enabled us to speak to the public more and more around harm reduction and drug use, and that some of the substances that we have originally banned versus drugs that are adulterating our drug supply and the relative harm of them. And that's been a national public education campaign by stealth and kind of accidentally along the way. So good relationships really underpin everything. And just to point to two examples, which Jen might also speak to from a different perspective, but I think underpin the relational examples, which is why I've pointed to them. We had an event, I can't even remember when it was, a year or two ago now, where we had an outbreak of fentanyl in just a sort of semi-rural part of the Wellington region. And the image in this news story on the slide is of the then head of our NDIB, which is where High Alert sits. And that's him posing in our office in his uniform. He purposefully decided to wear his uniform in our office in order to point out the good relationship, to encourage people to come forward and to know that it was a harm reduction approach that was being deployed. And it was an incredibly powerful news item, having him and I stand over a spectrometer to role model drug checking. So that really intentional, high trust, well-coordinated relationship was super helpful. And it resulted in no further, well, there was one further harm event, but non-fatal, fortunately. But beyond that, no further harm events from that fentanyl notification. Now, the fentanyl at that time had been sold as cocaine, and you all know just how different the quantities of cocaine versus fentanyl would be. The other example that I've popped up here was a very recent example, and High Alert actually weren't involved for various long reasons, but we lent into our community relationships with this one. So we had a community organisation, our Auckland City Mission, had distributed some lollies as part of food packages that they distribute routinely, that had turned out to be what we think was most likely methamphetamine that had been packaged for smuggling purposes, that had somehow made its way into a donation box to the Auckland City Mission. And our very, our pre-existing relationship with the Auckland City Mission meant that we were able to respond within hours of that being, them identifying there's something wrong with this lolly, us testing the lolly for them, realising what it was, and getting information to the national poison lines, the media, and everybody else we could very, very quickly, and a media stand up the very next day. So really, I can't underscore how important the relationships are in actually successfully preventing harm, that the job isn't just testing somebody's substance, and the job isn't just issuing a notification. The job is connecting in with community to help prevent harm. Could probably go on with 1,000 more examples. Probably ready for the next slide now. Thank you. I wanted to point to some of the things that we are still lacking here, and I think some of these you will have patches of. So everywhere you go in the world, we've managed to secure some things, but not the other things. The Drug Foundation put out a report last year, or a plan of what we would like to have if we had a fully organised overdose prevention approach here. That's partly because we haven't had a lot of work done on overdose prevention in New Zealand in the past, so we put a big focus on it. We informed that paper through connecting in with international colleagues, particularly in North America, Canada, and Scotland, to understand what they were doing really well. And we put that together into a plan. So if that's helpful to people, really happy to share a link. One of the things that I'm aware the UK have just gotten off the ground that we've been trying to engender here is the lag time between coronial information coming out and fatalities occurring. So High Alert is able to access some information around fatalities and mortality and use that to feed into their notification process. But at a more community and public level, and ourselves included, unless we're whispered it and aren't meant to know, we don't know how many fatalities have occurred due to nitazenes in New Zealand so far. We have heard just this week that the UK have just released public information about nitazene fatalities, and I think are intending to continue to do so. So we're hoping to try and get something like that stood up here. We do know back when the synthetic cannabinoid crisis happened here, that our coronial office made an exception and put out some interim results. So we'd really love to see interim results published. But we've got a long way to go when it comes to overdose prevention here, and most of those things we're still trying to get going in New Zealand. And just last slide, and I think I'm out of time. Moving on to really, I think, we have, many of us in different parts of the world have been championing drug law reform for a long time. We've been championing decriminalisation for a long time. Our concern is that it's no longer adequate to only be talking about decriminalisation. Our drug supply is getting increasingly toxic and increasingly diverse with new psychoactive substances, and also increasing in volume. And we have no control over it other than policing and border control. And we think it's no longer responsible to only talk about decriminalisation. We haven't quite worked up our policy on the supply side. Obviously, supply around low harm substances is relatively straightforward, but we're really keen for more conversation to happen around what safe supply might look like. And I'll leave you with some parting thought from the deputy head of the police force from British Columbia when I was over there last year. I said, if you could go back in time, imagine New Zealand's back in time compared to you guys, which is often how I think of us. If you could go back in time to before fentanyl, what do you wish you had pushed for? And her response to me was safe supply. I wish we'd push for safe supply. And I said, well, safe supply or regulation, regulated supply? She said, they're kind of the same thing to me. So just to leave you with that thought. Kia ora tātou.
Amazing. So much covered in such a perfectly on time space of time. So you nailed it there, Sarah. Thank you so much. I think we have a lot of shared visions and different challenges, but I think that point about collaboration is really key. Next up, I'm just going to move on and we'll come back with questions and discussion at the end. Next up, we've got Jen Vermeulen. As I said, Jen's the supervisor and online channels manager at High Alert. Nicely segued on from Sarah's introduction. At High Alert at the Drug Information and Alerts Aotearoa New Zealand. Jen's an experienced digital communications professional and writer, highlighting the comms side of things, and has been responsible for the public-facing channels of New Zealand's early warning system since its launch in 2020. Previously, Jen was a journalist in Sydney before transitioning to digital comms in London, and in New Zealand, Jen honed her digital skill set at New Zealand Rugby before joining the Labour Leader's Office as social media manager to Prime Minister Jacinda Ardern, where she gained experience communicating complex policy information to public audiences, which is key for this kind of role, I guess. Jen's deeply motivated by the potential of social media and digital platforms as tools for social good, and strives for growth and improvement to ensure High Alert remains a world-leading drug early warning system, which it is. So Jen's going to chat to us about High Alert in a moment. As soon as you're ready to share your screen, I'll throw over to you. Thanks again, Jen.
Great, thank you for the introduction. And always lovely to follow on from Sarah, who we work very closely with the Drug Foundation. They're a very important partner to us. So it's great to be able to talk to you guys about partnership in particular. Unfortunately, not my personal passion project of communications, but you know, there's a lot to discuss. So what I thought I would do is just give you an overview of New Zealand's drug early warning system, and we'll look at the information sources we receive and how our partnerships are really important in that. Then I'll step you through our notification process, and I'll take you through some case studies of 2 Nitazene examples. And yes, I also say Nitazene. So who are we? Drug Information Alerts Aotearoa New Zealand. We were founded in 2020, but we was established by the National Drug Policy from 2015 to 2020. So we're a multi-organisational and multidisciplinary initiative, bringing together both government and non-government organisations. We are funded by the Ministry of Health, but we are housed within the National Drug Intelligence Bureau, which is a multi-organisational work group that sits within the New Zealand Police. So we're made up of members from the Health Department, Customs, and Police. Our purpose is to act as an early warning system to help reduce acute drug harm in New Zealand. So we want to do that by identifying harm where it's occurring, providing evidence and understanding of those outbreaks of harm, and in some cases, ideally anticipate potential harm related to drug use before it occurs. So in this context, acute drug harm refers to sudden surge or increase of intense harms associated with drug use. As Sarah mentioned, the synthetic cannabinoid crisis, which claimed the lives of 70 people, is an example of acute drug harm and was something that established the need for this early warning system. So we launched publicly in June 2020 under the public brand of High Alert, and we had a website and an email subscription function. Over the last 4 years, we've also expanded this to include social media channels. Our main focus is to issue alerts and notifications, both to our partners, but mainly the public. And that is when we identify something that poses a significant threat to people who use drugs. So to do that, the public can sign up to receive these notifications via email through our website, or they can view them on the website itself. The website also has a function where the public can report unusual or unexpected effects from drug use, and that is to allow them to have a feedback loop and give them some options, basically, because previously there was nowhere really for them to go. And we also offer the function for healthcare providers to sign up through our website, and then we'll send them some extra information that's maybe not quite ready for public consumption, or it's just a trend that we're monitoring that's not necessarily leading to harm, but something that we want people to watch and maybe report back to us on. I have to stress that it's important to note that High Alert is not enforcement focused. So we do sit within police, but we are concerned with reducing harm. All the information that is provided to us stays within High Alert. We do not share data with enforcement. It cannot be used for any criminal prosecutions or anything like that. We have a very clear delineation with that. And it's really important to the public trust in High Alert for obvious reasons that we aren't really associated with police too closely. In terms of how we work, we are a team of 4. So there's myself, I'm the online channels manager, and also the supervisor. And then we've got 3 intelligence analysts who do most of the scanning and the really important work. And then, of course, we're supported by a network of health professionals and social services groups. So what does that all mean? Oh, can't quite get the slide to work. Classic. There we go. So the most critical role of our early warning system is the scanning. We monitor a range of information sources to identify harm that has occurred or where harm could occur. Our understanding of the drug environment is based on the collective input of information sources. So each source provides its own piece of the puzzle, although some would be considered more useful or more valuable than others. The frequency in which we monitor these sources vary. Some of them are monitored daily, others far less frequently. And these range from proactive to reactive. Now, as an early warning system, ideally we want to be operating in the proactive space. So that's what we're always striving to achieve. Now, although we do have good coverage of the drug market through our sources, there are a few gaps that we are looking to address, and we're constantly striving to improve our ability to monitor harm environment. So there are various strengths and limitations with the data sources, but the key risks we're really looking for include if there's particularly potent drugs, any drugs that are being misrepresented as another, or the adulteration of drugs, and of course, new harmful drugs or novel psychoactive substances, as Sarah mentioned. So when it comes to our regular scanning, I'll just take you through some of our information sources. Now, because we're a police-based unit, that means we have access to police data, which is incredibly useful. So we scan sudden death cases daily. So this refers to sudden deaths reported to police, and we can review these to identify if there's instances of acute drug overdoses involved with these cases. Now, if there is something of a particular concern, we can then liaise directly with the investigators to have any samples collected and analysed. We also scan police occurrences daily, so that's the police jobs related to a keyword search. These include live events entered from emergency and non-emergency calls made to police. We also look at reports entered by police officers attending these events, and then anything that is originated, maybe not through the public necessarily. So the other one we look at daily is ambulance data. High Alert very early on formed a close working relationship with our ambulance providers, so that's St John's and Wellington Free Ambulance, and we receive a daily data pool from them that contains drug-related ambulance calls for service related again to a key set of terms. Through the National Drug Intelligence Bureau, we also have access to New Zealand's wastewater data, so we receive monthly reporting as it becomes available. The program tests for certain drugs and wastewater to make conservative estimates of consumption and provide a really good oversight of longer term trends. And I know we'll be hearing about wastewater a bit later. Just for context, the New Zealand context, the drug and wastewater program tests 46 sites across New Zealand, and we look at it across 7 consecutive days every month, or every second month if it's a really small site. And this provides drug consumption data for approximately 75% of the population. So we're looking for indicators of consumption for methamphetamine, MDMA, cocaine, heroin, and fentanyl. And in the last few years, we have been adding some synthetic cathinones as well, like dimethylpentylone. And we're constantly looking for new opportunities. We work really closely with the ESR who run that program. As I mentioned, because the NDIB is multidisciplinary, we also have a customs angle here. So we receive monthly customs seizure data, which provides an oversight of all the controlled substances seized at the border for the month prior. And that's, again, quite useful for identifying longer-term trends. Now, we have a very close working relationship with our drug checking providers across the country. And so that is a really valuable source of information because it shows us what is happening in the community currently. Drug checkers will send through all their results from a clinic, usually within 3 days after the clinic, and we then collate all of that into one big picture. Drug checkers will also reach out to us if they see anything concerning, and that's immediately. We'll just pick up the phone and give us a bell, and that very often will lead to notifications because it's so immediate. It's just a really good insight into what is going on. We also regularly scan online drug markets, so that includes the dark web markets, and that's just to note any particular changes, new substances coming in, or any sort of trends that we're seeing. And through our health contacts, we receive hospitalization data, which provides an oversight of drug-related admissions to hospital based on self-disclosure or toxicological analysis. And then there's the more ad hoc things that we look at, so drug forums, and of course we stay across any relevant international reporting. This really is the strength of High Alert. Our network of partners provides us an oversight and an option to mobilize a community in a way that didn't previously exist. Before High Alert existed, there was minimal coordination to bring these people together, to bring different groups together, or understanding what people are actually seeing on the front lines. There was no structure in place really to allow harm occurring in one part of the country to be connected to harm occurring somewhere else. But now that the High Alert analysts are connected into this network, it not only provides a bigger picture view of the whole country, but it also acts as a connector for different partners. So as Sarah mentioned, we had that meth lolly example, and I think this is such a great example of showing how all of the community work together, not just the Drug Foundation's partners and the community of practice, which is so important to engaging action, but also just how High Alert could help and support, because the Drug Foundation immediately called us when they became aware of that, and we could then link them in with the Auckland Police investigators. And then it set up a whole government response that involved, the primary industries and various people, and setting up door knocking, and 400 families had to be visited. So you can imagine it was quite a large scale operation. And we were able to mobilize that really quickly because we had a really great relationship with the Drug Foundation. So what happens once we've done all that scanning? Should something of concern be identified, we will then begin to dig a bit deeper into the matter. Our analysts will engage with relevant parties seeking further information and context. Now, what we're often looking for is, what was the drug sold as, or what was it presumed to be? How prevalent do we know it is, or do we think that particular substance is? Did other people experience similar reactions, or was it a one-off event? Was there polydrug use involved? All these sort of questions. Because at this stage, what we're really trying to do is build a picture and gather as much information as we possibly can so that we can have a robust analysis. Now, ideally, when a harm event occurs, a sample of the drug itself or blood samples will be available so that we can send it to the lab for analysis. So this will often involve one of our analysts engaging directly with police or emergency departments to arrange for samples to be delivered. So we have a really great relationship and work really closely with the Institute of Environmental Science and Research, which is ESR, and they're the New Zealand government research agency who provide drug chemistry and toxicological analysis. Now, lab analysis is the gold standard for high alert and for our notifications, and that is because the scientific rigor gives our notifications credibility. It's not just our gut feeling. We've got something to back it up when people are understandably suspicious when you talk about drug harm, because for all they've heard for a very long time is that, just say no to drugs. So trying to get people to actually take you seriously is a big part of our work. When we do get lab analysis, it also allows us to provide a really detailed harm reduction advice. But saying that, it's not always necessary to have lab results before issuing a notification. If we are confident that we can go ahead with something, we won't wait for analysis. So once we've developed an understanding of what is going on, we will then run the situation through the standardized risk assessment, which is this matrix that is up on the screen. Each scenario is weighed and we get a score which informs the analyst what to do next. And that's just to develop a little bit of consistency across these incidents, because every harm incident is very unique and there's only so much you can do, but we do have different levers we can pull, and this helps us decide which one we were going to use. So we can either do a social media post, we can ask our partners to go out with something, as the Drug Foundation might do. We could do a harm reduction article, which goes up on the website, or we can issue a notification or an alert. When information is identified that might indicate a risk of harm to the wider community that meets the threshold, we will go out with a notification. So since we have launched in June 2020, we have issued 30 notifications and alerts, and these have been nationwide and have related to various substances. The most have been about synthetic cannabinoids. We've done 8 of those. We've had 6 for synthetic cathinones, 6 for opioids, a couple for benzodiazepines, and then a fair few for G-type substances as well. Now, how does this work in practice? I thought I would take you through 2 case studies here. The first time we encountered a nitazene in New Zealand, and then our most recent example of encountering one. While the misuse of synthetic opioids in New Zealand continues to be assessed as low, if we are to see an increase in harm, we believe it will be as a result of nitazenes, and particularly pressed tablets containing nitazenes, like you will see in these case studies. These tablets are often sold at low cost compared to other illicit opioids, and it's also possible that the tablets are perceived as more appealing than intravenous use and may attract people who weren't previously consuming opioids. So we have issued 4 notifications to date specifically regarding pressed tablets containing nitazenes, and this was the first one issued in March 2022. Now, we were alerted to these pills after drug checkers Know Your Stuff found a fake blue 30 milligram M30 oxycodone tablet. It was purchased in the Wellington region. In this case, it was a misrepresentation of a legitimate tablet because these are not prescribed in New Zealand, so we were initially automatically suspicious. We liaised with the drug checkers to get this sent to ESR, and analysis then confirmed that it actually contained a nitazene, which you all know acts really quickly to produce strong sedative and depressant effects. And we also knew at the time that the substance had been linked to deaths in North America and the United Kingdom. And we knew that it was available on social media and had been available in the Wellington region. So we wanted to immediately act on this one. And of course, the primary risk of harm here is overdose, with the variable amounts of active drug in the tablets in the same batch. And also the effects will differ if someone is taking it, assuming that it would be oxycodone instead. So we issued a notification, and through our activity, we directly reached 24,000 people in our first 4 days. We also got really strong public engagement with people who had taken the substance and experienced negative effects. This is one of the interesting things when we issue notifications, is that we often see positive engagement from the public following a notification, but also notably with dealers. On more than one occasion, dark web listings have been altered after we've issued a notification to include the harm reduction advice that we published. And on one occasion, someone actually took down a listing and stopped selling the substance because they did not realize that it had been misrepresented. So that's unintended consequences, but a good result all the same. The most recent notification involving a nitazene is this one, which was issued in May this year. So this was again identified at drug checking. So after a blue tablet was presented to the New Zealand Needle Exchange Program DISC drug checking clinic, again in Wellington, and it was presumed to be diazepam. So liaised with ESR, and it showed that the tablet contained a nitazene. And then in the following weeks, further tablets were identified in a drug checking clinic in the Bay of Plenty region. So that's further up north. This is another way we see our notifications actually working, because we often hear about an increase in attendance at drug checking clinics when we've issued one. We had that over the summer period as well, when we identified some alpha PVP related substance being misrepresented as MDMA. And then as a result of issuing that notification, we had more people coming to drug checking, showing up with their powders, getting it tested. So all of that helps to reduce harm in the long run. Of course, counterfeit benzodiazepines containing synthetic opioids has been increasing internationally. And this was the first time we actually saw this trend in New Zealand. So in total, we've issued 5 notifications about nitazenes, and we've reissued 2 of them as they resurfaced. So they sort of disappeared for a couple of months and then came back up, so we reissued them. In general, opioid consumption in New Zealand has traditionally been quite small relative to other drugs, and synthetic opioid consumption makes up an even smaller portion of that. Over the last 2 years, we have seen an increase in these substances on the market, and noting that it is from a very low baseline, but the growth appears to have occurred within the confines of the existing opioid market and is largely driven by that small group. But relative to their prevalence in the market, we all know that nitazenes cause a disproportionately high level of harm. So it's an area we monitor very closely, and we have developed these indicators to help us keep track of the market. Now, this particular one that's up here is from November, where we had 6 indicators experiencing a change compared to the previous 12-month period. Nothing has significantly changed in that time. Maybe some have even slightly decreased, but we are monitoring it. We constantly check in on this because we do know that this is having such a significant impact internationally. In terms of the effectiveness of an early warning system, I firmly believe it's only as effective as the people that you are able to reach. You need to be able to get to the public with harm reduction information if you're an early warning system, because otherwise you're talking to no one. So while our message is clear, it's always safest not to use drugs, we know that we have a responsibility to ensure that we always take steps to minimize harm caused by drug use wherever we can, and while also investing in promotion of health and well-being to reduce drug use. So a key focus for us in our first 4 years has been building brand awareness and trust in High Alert and the information that we provide, so that we ensure that when we do issue a notification, the public take it seriously and they take the relevant action. Our brand building work is still ongoing. It's incredibly encouraging, though, to see that we have really clear engagement with our content. We have had over 1 million visits to the website, and we've built an email list of over 8,000 people, members of the New Zealand public, and then an additional 1,000 healthcare professionals. This is really important because we don't want to rely on algorithms or other ways to reach people. We want to be directly able to get in front of people when we need to. And we've had a really good response with that. We have consistently high email open rates within the first hour of when we issue a notification. People seem to take it seriously when we do. As Sarah mentioned, there is a weakness there because we appreciate that there are some communities that we don't necessarily reach because maybe they're not online. And so we rely on our community to help get those words out. We rely on the healthcare professionals to be across this so that it can help people they deal with, and community service providers who are actually out there on the ground who can relay this information to people who need it. But through our social media activity, we have also reached over 2.4 million Facebook and Instagram users, and our TikToks have been viewed over 1.6 million times. So it just shows that there is an appetite for this type of information, and it just supports the enormous potential when you actually offer people harm reduction advice, they will engage with it. So to sum up, as an early warning system, we regularly monitor a number of sources nationwide to assess the risk to our communities. We then generate a number of outputs, the most important being our notifications and alerts, as shown in this presentation. But we do also have other mechanisms to get information out. We've developed these other outputs because we want to reserve notifications for our most urgent messaging to ensure action is taken when it's most vital. But ultimately, we couldn't do what we do without our network of both government and non-government partners to provide us with the information we need to identify that harm in our communities. We are continually striving to build those relationships and find new opportunities to help us build a bigger picture so that we can prevent serious harm before it happens. It's an ongoing piece of work, but it feels incredibly important and vital. So yeah, thank you.
Thanks so much, Jen. A lot covered, even though you didn't focus on the comms side of things. I think you highlighted the importance of having that kind of expertise in such a big system. Lovely segue, I think, into a chat about an example of what's happening here in Australia. It's not the only surveillance and warning system we have, but it is an example of a coordinated one. So we've got Jared Brown, who is the manager of toxicity response, epidemiology and surveillance at the Centre for Alcohol and Other Drugs at the New South Wales Ministry of Health. And over the past 6 years, Jared and the team, his team have developed the New South Wales Health Drug Surveillance and Early Warning System in collaboration with a range of different stakeholders. Jared's an advanced practice pharmacist in clinical toxicology with 16 years experience at the New South Wales Poisons Information Centre in a range of roles, including senior poison specialist, in toxicovigilance research and operations director. So very passionate about rapidly identifying and responding to emerging poisoning threats. Trying to use my mouth faster than my brain is going. So Jared's going to chat today, as I said, about the New South Wales Surveillance and Early Warning System, and I'll throw over to you, Jared, when you're ready to go.
Thanks very much. And it's so great to be able to follow New Zealand, as a lot of the key components have already been covered. So I'll try and focus on the New South Wales perspective. I'm focusing on the surveillance methods and networks that we have in place in New South Wales. I don't have time in 10 minutes to cover the kind of impacts and responses to our drug warnings, but we do have some manuscripts in development around that, and I'm happy to take questions around that offline as well. So to start with, as kind of New Zealand's nicely painted, the whole system relies on a network of stakeholders and really valuing the partnerships that we have with a whole range of different organizations who we value each and every piece of information that comes from them. And that part of growing that network, which developed in 2018 in New South Wales, in terms of a coordinated system, that has relied on ensuring that the information that's provided is treated appropriately in terms of valuing it, but also respecting the privacy and confidentiality of that information and the governance arrangements to ensure that information is only released with permission from the data custodian. So as you can see in this diagram, I've tried to kind of depict the key stakeholders, but please don't be offended if you are another stakeholder that has contributed. There's just limited space that I can show here. But we see it spans a range of different partners, and that's part of what's needed, particularly around nitazene surveillance. You will see with some of the examples of how we've had to really spread the networks, and so it's always developing and growing. The network here, a key component, as has already been stated, is around the value of analytical confirmation. So working with toxicology partners, both from a clinical and an analytical perspective, has been critical, and ensuring rapid turnaround times and broad range of testing is available has been critical to the success of the New South Wales system to date. So I can't understate the importance of having those partners there, but also with kind of community members as well, and peer-based organisations, as they are the reciprocal nature of being able to get intel, but also to get the key messages out to people who use drugs, because that has been a critical component as well. And we are seeing more issues relate to kind of cross-border issues in terms of things that are happening across multiple states, and the networks of the Prompt Response Network have been critical to establishing the ways to share that information. So I've specifically called out some of the examples of the data sources that we use in New South Wales around nitazene surveillance. So as the central coordinator is based in health, it's kind of slightly different in terms of the focus, but in compared to New Zealand, you'll see that there's a slightly more kind of health related data sources, but I'll quickly walk you through some of the examples there. So kind of opioid related ambulance call outs are really important. As we know, in Australia, a third of opioid-related ambulance call-outs aren't transported to hospital. So if we rely on hospital-based surveillance alone, that will not capture the full scope of what's happening in the community related to overdoses. ED presentation data, we really rely on a coordinated system that's been in New South Wales for a couple of decades, which kind of pretty much captures all of the state-based, all of the emergency departments across the state, and using that data in real time to generate signals around if there's an increase in AOD related presentations. We also do weekly review of a line list of cases that present across the state to identify cases that appear like that they may need further investigation or in toxicology analysis. And we work closely with a range of partners to investigate those signals. The Poisons Information Centre and toxicology services across the state have been a really important notification source, and working with the coroner and forensic medicine services to get access to regular feeds of toxicology data from coronial casework has been important to identifying emerging cases of concern. So both a monthly feed as well as a monthly feed of data, as well as notifications from the lab directly when they have a case of concern. We have the Prescription Recreational and Illicit Substance Evaluation Program, which has been operating for the past 5 years. That program allows for anyone to notify us of a case of concern, which might be a cluster of overdoses of heroin overdoses, for example, in a short period of time in a local area. That would trigger a notification, or someone who has kind of severe and unusual toxicity. Nitazenes are a bit more complicated because they appear like any other opioid overdose, and that's why we rely on clusters or characteristics such as high doses of naloxone or naloxone infusions to signify a potential concern. but we again rely on a range of stakeholders to report signals to that system, and then organise extended toxicology analysis on blood, urine or substance where available for selected cases, and that's done in a rapid turnaround time. We work with law enforcement agencies such as New South Wales Police Force to analyse substances that may not be routinely subject to analysis. So we do, there's a project called Cosmos where analysis of key substances of small quantity police seizures are analysed to inform substances that are in circulation. We've also worked with analysis of discarded drug residue in syringes from sharp spins. We work with opioid treatment program approvals where the primary drug of concern is reported to identify any reports of intentional nitazene use, and then working with a range of stakeholders from interstate and even media monitoring to really canvass widely in terms of where clusters of overdoses may be occurring. So all of that data is great to have, but when you have a lot of data, you need someone to analyse the data and make sense of it to really identify signals. So there is a central coordinated team within the New South Wales Ministry of Health that I manage to make sense of that data, and that kind of consists of people from a kind of analytical perspective, but also clinical expertise that we access. So that data is collated, there's an internal risk assessment done, and then when it meets a certain threshold, a further assessment by either internal experts, or we have a standing panel on toxicity risk, which is an external panel which comprises a range of organisations, from peer-based organisations like NEWA, clinical toxicology, emergency medicine, alcohol and other drug specialists, and where a signal is of in a particular community, we have additional representatives where necessary. This just gives you a really quick overview. You don't need to kind of remember any numbers from it, but just understanding there's a lot of data that comes in, and then a lot of that data needs to then be sifted down to find those key signals, which then a smaller number of those will then proceed to a risk assessment that whether it's to the external panel or internally. This is some old data from up until June 2023. If we look at it now with our as part of the Prompt Response Network, they're developing a national signal register. We've been looking to improve our signal documentation for our lower risk signals to ensure that we align with the plan for the national signal register. And look, in recent times, we would say that there's probably about 3 per week in terms of a signal that is being assessed, and it is this year a kind of a higher activity than normal, but that potentially may reflect a change in the documentation process that is happening to align with the upcoming plans for a national signal register. The response options are quite varied, as kind of we've seen from the New Zealand example as well, and we similarly have different tiers in terms of our response of whether we issue a public drug warning or a targeted alert to clinicians, or it might be kind of a peer-based community notice, or just messaging through kind of festivals if it's a festival related concern, or just targeted messaging to the clinical toxicology network, but not necessarily going out to all New South Wales health clinicians. And to finish on, I just wanted to walk you through some of our nitazene drug warnings, and just to show the diverse range of sources that have been used to trigger those. So and also this is on the back of, back in 2020, 2021, we did have a number of acetylfentanyl and fentanyl detections which triggered drug warnings. This is focusing on the nitazene ones, that we've had cases where we've seen protonitazene in vapes that people were using. That was reported from a drug withdrawal management unit. We've had counterfeit alprazolam, which contained nitazene. That was triggered from analysis of routine police seizures that identified that with a prompt notification. Earlier this year, we had Red Bull tablets that were sold as MDMA, which were found to contain protonitazepine. That was notified by an on-site medical provider at the festival to the Poisons Information Centre, who then further notified, and then a coordinated work with the emergency departments to get blood and urine analysis, testing of substance that came in with the patient or with a patient, and then also testing of further police seizures that occurred from that festival. We've also had nitazene, isotretinoin found in a powder that was initially notified by the local police service, and then a collaboration with forensic medicine, the toxicology lab, and the coroner to investigate that to then trigger a drug warning. We've had protonitazepine overdoses in Sydney, where people thought that they were using nitazene. That was detected through our ED surveillance system based on keyword searching of a nitazene-related search term that was in their triage text. We had clusters of heroin overdoses in which had nitazenes detected in them on the central coast of New South Wales. That was notified by the Poisons Information Centre, and then collaborating with local AOD service, ED and ICU to organise sample testing, and then ultimately, because there were deaths involved as well, coordinating with forensic medicine and coronial services too. And one of the most significant cases that we've worked very broadly with is earlier this year, we had a cluster of heroin overdoses associated with nitazenes in Western Sydney. That was initially notified by NEWA, our kind of peer-based harm reduction agency in New South Wales, who worked with the local NSP in the area, and then subsequently with the emergency departments there, police, ambulance, who shared data. And then ultimately, because we couldn't actually identify the source of the issue based on our routine means, we then went down the path of the NSP collecting sharp spins from the area and getting those analysed by the University of Technology, Sydney, and that subsequently then did identify the nitazene responsible for all the overdoses, and confirmed by our illicit drug analysis unit lab. And then finally, which will segue into Richard's presentation, we also did do some follow-up testing of wastewater in the area to see if there was any ongoing evidence of nitazenes in the community several weeks after the initial issue, which thankfully did not show nitazenes detected at the from that analysis. So I'll finish up there, but thank you.
Amazing. Thank you, Jared. And I do acknowledge that 10 minutes is not a lot of time to talk through an incredibly huge piece of work. What I'm actually hearing is like just coordinating all those different sources and the agility, you know, to pivot as you need to identify things is quite crucial. And I'll probably come back to the resource question when we get to the Q&A. One of those sources, as Jared beautifully segued on my behalf, is obviously wastewater analyses. And so our final speaker for today is very much not least, but last, is Richard Bade. So Richard's a senior research fellow and ARC DECRA fellow, or ARC, I should say, DECRA fellow in the Queensland Alliance for Environmental Health Sciences, or QUASE, at the University of Queensland. Richard holds a PhD, which he obtained in 2016 before joining Population Health Chemistry Group in South Australia, where he focused on developing methods for detecting illicit drugs in wastewater, what we're talking about today. But his research interests include surveillance, detection and identification, specifically related to new psychoactive substances in wastewater, obviously, and exploring the impact of chemical and pathogen exposure during mass gatherings, which is an interesting one. Richard's involved with the National Wastewater Drug Monitoring Program, who does all of our wastewater monitoring, and leads an international consortium exploring the prevalence of NPS, or new psychoactives, worldwide. And as we've said, he'll talk to us about his novel method for detecting nitazenes, or nitazenes. I do use it interchangeably, just not today, in wastewater. So I'm going to throw over to you for the sake of time, Richard, and when you're ready, shoot.
There we go. Cool. Thank you for the introduction. Also, thank you for the invitation to be here this afternoon to present on some of the work we've been doing, looking at nitazenes in wastewater and how it can be used as a supporting tool for drug surveillance and early warning systems. also only have 10 minutes, so hopefully this will be understandable in that length of time. So some of you may not have come across wastewater analysis or wastewater-based epidemiology before, and it's really nicely put together on this figure, which was made by one of my colleagues, Jake O'Brien. Basically, within a wastewater treatment plant catchment area, there are residential areas. So you've got your houses, apartment buildings, hotels, townhouses. You've got community-wide facilities like stadiums, shopping malls, event centers, offices, and industry. And you've got community services such as hospitals, universities, prisons. In all of these places, there will be toilets. People need to use these toilets during the day, so they do. The excrement will reach the sewer network and inevitably end up at a wastewater treatment plant. So we can take a sample from the inlet of the wastewater treatment plant before any treatment is made to give us an example, an indicating of what has been consumed within the community during that period of time. We then take the sample back to the lab, we process it, and then we analyze it on our instruments to give a concentration of the compounds that we're interested in. So wastewater analysis has been around for a long time. So for more than a decade, it's been looking at various exposure patterns, for example, exposure from environment and food, including pesticides, mycotoxins, plasticizers, health markers, including pharmaceuticals, antibiotics, COVID-19, of course, and lifestyle markers, including alcohol, tobacco, caffeine, illicit drugs, performance and image-enhancing drugs, and new psychoactive substances, which do include nitazenes. So a lot of work has been done in the wastewater space, but there's a lot of things that wastewater cannot tell you, and that's why it's a really great complementary tool. So for example, we can't tell individual behavior profiles. So as I showed before in the figure, it's very much a community tool to understand what's happening within a community area. So even if we do find detections of nitazenes, we can say it's within an area, but we don't know where or who has been consuming these compounds. The other issue is dilution effects. So for example, if you're looking at low dose markers, which is what these nitazenes are, it can be difficult to detect these because the sensitivity that you need to be able to find these to begin with is really high. And when they're diluted, it makes it even more difficult to find. So we have very sensitive methods to try to detect these nitazenes. And in saying that, if you have a small proportion of people within a community who are consuming these drugs, so for example, if you have 5% of a community, which is probably overestimating it, who are consuming nitazenes, 95% are not, but these 95% will be diluting the 5%, which makes it more difficult to actually find these nitazenes in wastewater. Not saying that it is impossible, but saying it there are limitations around finding nitazenes through wastewater analysis. We also cannot provide reasons for why use may be changing. So if we have ongoing surveillance, we can see changes over time that might increase, it might decrease, but we cannot say why these might be increasing or decreasing. However, it is a great complementary tool, and I will show in the coming slides how we have tried to incorporate it into other surveillance measures. And it can provide relatively real-time data. For example, during the COVID pandemic, we were getting analyses done within a day to understand how COVID was prevalent within our communities, and it can also be expanded for other substances as well. There are lots of examples of where wastewater has been used. I won't go into it here, but happy to answer questions after the presentation. So we have developed a method for looking for nitazenes in wastewater. Our methods are quite sensitive, so we can get around limits of quantification, which is the limit that we are confident that we are able to say that this is actually present, of around 1 nanogram per liter, which is the equivalent of 1 drop within an Olympic-sized swimming pool, which just shows the sensitivity of the method. We've applied this to wastewater samples collected not just from Australia, but also around the world as part of an ongoing international wastewater surveillance project. And I'll show you some examples of what we've found over the past 2 years when we started looking for nitazenes as well. So we've been looking in 22 countries. I've got 62 sites involved in this project at the moment. And we were able to detect some nitazenes in sites from the United States and also Australia. Now, the data on the coming slides is, I have to say, it's preliminary. It's not published yet, so just bear that in mind. It's still under peer review. We found protonitazene in 4 separate sites in the United States in 2 consecutive years. So the red and the purple colors, which you may or may not be able to see, are from the 23-24 New Year period. The black and the dark blue color are from the previous year. These are from different states, actually. They're from different sites, but we were able to detect protonitazene at really quite low levels. This was around about our limit of quantification. And if you look on the left-hand side, the estimated mass loads around 0.3 milligrams per day per 1,000 people, which is sort of what we would expect if it was consumed within a community, considering the size of the places that we were looking at. And we did share this with our collaborators in the US and also with colleagues who work in the forensic field, and it was not unsurprising for them to see protonitazene in these sites. What was interesting is that in the most recent period, we found 2 nitazenes, so protonitazene and etonitazepine, in a site here in Australia. If you look just at the units, it's far higher than what we saw in the United States. It's up to about 300 times higher than what we saw there, which was far beyond what we would expect from consumption of these compounds. So we actually analyzed these samples quite a few times just to try to confirm that it was indeed protonitazene and etonitazepine, and we were able to do that. And we passed this information on to the health and law enforcement agencies within this jurisdiction to see if they were able to confirm it with any of their other data sources. As Jared and also what you've heard in the past couple of presentations, there are a lot of other data sources that can be used to try to triangulate nitazene consumption within a community. And they were not able to confirm it with any of their other data sources. So we assumed that it was probably direct disposal. Again, we cannot confirm this, but just based on the huge amount we were able to find in the wastewater and the trends that we're seeing with this massive peak on the 30th of December and then dropping down over the coming days, it was probably direct disposal. So potentially someone had a bad batch of something and they did not want any more, threw it down the toilet and thought it was forgotten about, but it was not. And yeah, just to conclude, I think my 10 minutes is probably up. So wastewater-based epidemiology, wastewater analysis can be used as a complementary tool for nitazene surveillance. It can provide an understanding of community exposure. We have long-term ongoing surveillance. We can potentially act as a pseudo early warning system if we start seeing detections of nitazenes or an increase in their use. We can inform health agencies to ensure that interventions can be put in place before serious harms occur. Has to be said that infrequent consumption, also with the nitazenes being such low levels, it can be difficult to detect them all the time through wastewater analysis, but we're always refining our methods to ensure that they're kept up to date. And we're always working with health authorities, forensic agencies here in Australia and also around the world to ensure that our methods are kept up to date with the most relevant compounds, not just nitazenes, but all NPS and illicit drugs. So yeah, thank you for your attention. Happy to answer any questions if there is still time.
There is still time. Thanks, Richard. I think it's actually, yeah, we hear the term wastewater a lot, you know, sort of when reports come out and things and they get discussed in the AOD world, but I don't think a lot of people understand what actually goes on and what it means and what's involved in the process. So that was really valuable very much for that, if not all the other reasons. So thank you very much for your time. I might just quickly ask you, and I might have missed it while I was scrolling through some of the questions, but sort of what's your standard when you're doing your national wastewater? What's your turnaround time? I'm just thinking in terms of trend monitoring versus early type of detection, or could you pivot and move and do something if there was a cluster that you wanted to investigate?
The main difficulty that we run into is just receiving samples. So shipping samples from various locations. It's part of our national program with getting samples from Western Australia, South Australia, all around the country, being sent either to our colleagues down in Adelaide or to us here. And it can take a while to receive the samples.
Yeah.
And
so that's they're coming to you.
Yeah. Sample pre-treatment can also take a while. So our turnaround time is relatively long.
Yeah.
But it can be shortened if we know what we're looking for and we're able to receive samples relatively promptly.
Yeah, that's interesting. I just want to thank thank you again. Thanks for speaking with us today. And I want to thank all the other speakers who have been diligently responding to some of the questions as they've been coming through, which has been great. That saves us. We've got a few minutes for some more time. So I'm just going to shoot with those. Jared, you responded to a question around increases in nitazenes being sought purposefully or taken. And thank you for responding on your observations in New South Wales being sort of a mixture of intentional/unintentional use. I wonder if it's just worth pointing out that the detections that you see or the clinical cases that present maybe after experiencing harm would be 50-50, not 50-50 of the community who would be using nitazenes. I mean, obviously that's not the question that you're answering, but I just thought I'd flag that. I'm presuming that intentional use and it's total presumption, intentional nitazene use in the community is relatively low compared to other substances. I don't know if anyone's got any comments on that.
Yeah, just in response to my comment, yes, that was relating to those where we have detected a nitazene, which were intentional, yes.
Which was obviously applied. I just thought, yeah, yes, it's worth pointing out.
Good to point out, yes. In terms of the intentional use, like we're talking about kind of like 10 cases in the past year in the context of many thousands of people who use opioids. So yeah, it's a very small number of the overall population of people who use opioids.
Appreciate that. And Sarah, you might think you want to follow up with something?
Yeah, I mean, I think it's a really important question because it's a bit of a change in, it's a huge change in our drug environments, actually having these ultra potent substances potentially being sought after versus people trying to prevent themselves from accidentally taking them. And so when we were in British Columbia last year, talking to people and them viewing drug checking as almost pointless and a waste of time because the community was seeking the most potent thing in any case, or the UK in the situation where the heroin community had quickly realised that actually the potency was advantageous. I think that's just a really important thing for us to be mindful of, and it's part of why we've been keenly trying to distribute nitazene and fentanyl test strips to empower the community to either make the decision around not taking the substance if it's not what they want it to be, or indeed at least being equipped with the information about what it is. But it's a real worry thinking about our most vulnerable, I hate the word vulnerable, but you know what I mean, more at-risk communities who often get in our country, our homeless community often have the worst substances dumped on them that no one else wants and are more inclined to take them. So whatever we can do to focus our resource, not just on the more well-to-do, able to navigate their own health and well-being, but the parts of the community who have less resource, I think is so super important as early as we can. Yeah.
Yeah, I agree wholeheartedly, and thank you for coming back to priority populations or and just highlighting the importance that we focus on all members of our community in any responses that we do, because it is critical, and some groups definitely do sometimes get overlooked with some systems. And I guess the other thing is we don't want to there's the whole thoughts about the unintended consequences of drug alerts and warning systems and conversations about AOD. And I think you point out the key point is making sure that the right people have the right information in their hands to make informed decisions, regardless of what those decisions are, and that, you know, there's a lot of media and public awareness on Nitazenes at the moment, and for good reason. People are concerned in the community, but we also don't want to stigmatise people who are potentially seeking those substances out because of a range of reasons why. So all very, very valid points and good talking points and things to keep in our mind when we are talking about systems. I'm sitting in the wrong chat question. Sorry, I was in the answered question, so I was a bit confused there. Jared did mention a national alert scheme. There's a question there about that. That's the National Prompt Response Network, which has been in development over a period of time. And there is an interface there called the Know, which is has many functions, one of which is making drug alerts that are happening around the country in Australia, like a centralised place where you can access information. So we might be able to, Jared, I don't know if you're happy to pop in a link if you've got access to one. Oh, you legend. Great minds think alike. The Know is a really fantastic resource. It's fairly emerging, but I think one of the challenges we have we've talked today a lot about collaboration and the importance of that networking, that relationship management, even in Richard's work where he's collaborating overseas to develop appropriate protocols for things that will be useful for informing our surveillance systems. And I think one of the challenges with doing that in Australia, especially across jurisdictions, is we have a federated state with different drug laws, with different policies, with different focuses, with different cohorts and groups. And the Know is attempting to navigate some of the hurdles and challenges with that by providing us with essential things. So I encourage everybody to get access to and become familiar with that Know and sign up to their systems. I am just going to remind those of you who might be popping your hands up is the best way to ask a question is to pop it in the Q&A, and we've got a few more and a few minutes to get through a few more topics. So if you do have questions, now's your time for us to be able to coordinate those. I want to come back to the messaging, and we've touched on it a little bit about avoiding unintended consequences, but the messaging and the alerts themselves, or the communications, whether they're notifications, alerts, reports, and the different audiences and the work that goes into preparing those for different audiences and even deciding which audiences they should or shouldn't go to. And I think, I mean, Jen, clearly High Alert have a comms expert in their team, which is critical, but I think that background work is often overlooked in resourcing or even just sort of forecasting how much time and how much work it takes and how many systems have to be set up to sort of, for those things to roll well. I don't know what my question is. I guess I'm getting at, it's a question maybe for you, Jen, in establishing systems for good alerts and for brand recognition and credibility and trust in the system. And then Jared, I might turn to you if you have any comments on that as well.
Yeah, I think for us, the most important thing was just making it really as simple as possible. Like, we didn't want to overcomplicate the message for people, but we also really relied on our partners who already had established credibility. So drug checkers like Know Your Stuff, who had been operating in that space before it was legal, they had a lot of trust in the community. So bringing them on board, bringing the Drug Foundation on board early with the development of our early warning system, I think was really crucial to making sure that the community trusted us, because the people they trusted us. So that was really vital for us. And we also made the decision really early on that we wanted to own our own data. We didn't want to have to rely on Facebook algorithms in order to reach people. We didn't want people to have to come to a website to see if we've issued an alert. We wanted to be able to get it to them immediately. And so email, given, there are always cost constraints, ease of access, all these things to consider, the email system was the most effective way of achieving that. And it has worked really well for us. We see really high engagement with it. And, I worked in email marketing in a previous life, and I was genuinely shocked by how engaged people are in this audience. The fact that we can see notification at 6 p.m. on Christmas Eve and we will have a 58% open rate within an hour is just incredible. So it's an area we continue to want to grow, but we also acknowledge that there is spots where we aren't reaching people that we need to use, like people who don't have necessarily have access to the internet or aren't technologically savvy. These people do exist, and we don't want them to be left out. But they're developing different ways to reach them. That's why we have trend reports, so that we can provide more clinical advice as well. We rely on our contacts at the Poison Centre and at the Ministry of Health to develop that kind of clinical advice. So really differentiating between what is public and what is for professionals.
Jared, you got, I think New South Wales Health, I feel like you guys use a few systems, like you have an email, obviously an email list, but you also have some social media, and there's newer. I might let you speak to it.
Yeah, so we consider it based on what the particular drug warning is, in terms of whether it goes out through social media and whether it goes out through New South Wales Health social media, or if it just goes out through newer and kind of dance-wise kind of targeted messaging. So there is a assessment about and whether a media release is accompanying a drug warning. So there is a deliberate kind of deliberation about that, and that's done in collaboration with our expert panel in terms of what the channels to use, and they also review the content of the messaging as well, and also in line with the kind of media team within our Ministry of Health as well. So yeah, there is a kind of a deliberate strategy. Plus, yes, we have a direct mailing list as well that we send them out to, and we also have that the clinical pathway of. There's a separate system for in New South Wales Health for sending out advisories to clinicians. So we piggyback off the existing kind of public hospital, or sorry, public and private, but the hospital-based messaging system to reach clinicians. But then if it needs to go to GPs as well, then there's another system we have to tack on. And again, we just tailor it to every situation's very unique and has a slightly different approach.
I think the case by case nature of the work itself, really makes it tricky, isn't it? You can't just automate it and it all happens. There's a lot of thinking and a lot of brains and a lot of humans and a lot of resources involved in doing this well. I think that's a really key take-home message. I also want to acknowledge that, in terms of building credibility, trust, the right messaging, what the alert looks like, who it goes to, how it gets there, is probably a webinar of its own. So we could probably wax lyrical on some of the tensions and things that exist in that space, certainly another time. Because there are lots more conversations, I think, to be had. This is just the start. There is one more question, and it'll be our last question for the day, and we only have a couple of minutes. So I'm going to throw this one's to you, Jared. It's, what are the biggest gaps in our data sources? Now, I know you can't speak on behalf of Australia, but you are embedded in the space locally, and you're a representative expert. So I'm going to let you say, is there anything we'd really like to have data on that we actually don't have access to? And maybe, Jen, if you've got a really quick response or anything that you can think of, or Sarah can follow up.
So in Australia, I think that there are still some development opportunities. So compared to kind of other global early warning systems and surveillance systems. So in Australia, kind of national kind of drug checking data would be of value to surveillance systems, as well as routine analysis of discarded injecting equipment. They're two key gaps that kind of come to mind. There's exhaustive different ones that you can go to, but they're the two gaps that we have, as well as customs and AFP border seizures and real-time sharing of that data is another development opportunity with the early warning systems.
I think, great answer. And I think, there are systems we have in Victoria. We have EdNav, which is, similar but different type of system, and a few years behind in terms of its, a little bit behind in terms of its evolution. But I think what you're doing is setting up a space where some of those gaps can be filled as things, evolve over time. And I think in an ideal world, you probably won't have all of them filled ever, because that's just the nature of the beast. New problems will pop up and new technologies will pop up. Jen, I did say I was going to throw to you, but I'm actually going to call time because we are running out of time. So if you have any burning issues, you're welcome to dump it in the answers to the Q&A. But look, I just want to really thank you all for coming together. today. It's been such an there's so much information we can take away from this, and I think new conversations that we can get together and keep having about effective and more timely monitoring and what needs to happen in real time for us to be able to do it quicker, faster, better. So again, thank you so much. I know if people want to talk more about surveillance, I know there's an NCRED symposium coming up in November where I think Jen's colleagues from High Alert will be speaking, and other international warning systems. So that'll be a great program by the looks of it. But also stay tuned for some more webinars in the Pennington Institute series like today's one. We've heard your feedback and we want to host more sessions. So I've alluded to more conversations, and we certainly will organise those. They'll be going through to the end of this year and throughout 2025. So stay tuned. And I just want to encourage everybody online to just stay online for 1 or 2 minutes to complete our brief feedback survey at the end of the session. It really helps us, guide what content you want to hear about and ways we can improve the webinar series as well. But for now, I want to again thank our guests and for your time and generosity, and thanks to everyone online for sticking with us and attending. We have hit the 1:30 mark, so we are bang on time to wrap up. So I hope everyone has a fantastic rest of your Wednesday, and we'll see you again next time. Thanks, guys.